Hello, Dr. Ratapon.
Hello, Dr.
Hello. Hi, how are you?
Very nice to meet you.
Yes, yeah, lovely to meet you too.
Yes.
I'm sure we can.
Hello, everybody.
Hi,
Yes.
everyone.
Hi.
I guess we can start now, Dr. Ratapon. It's 8 o'clock. Well,
yes.
8 o'clock in South Africa.
Please, please.
Good evening, colleagues. It's my pleasure to welcome you again to our second Geeks Zoom meeting. Dr. Ratapon from Thailand will be assisting me with co-chairing on this session. And thank you so much, Dr. Ratapon. And yes. Dr. Uma sent his apologies. He's in transit flying between the countries. I'm not sure where he's flying to, but he sent his apologies that he was unable to join us. Hence, he asked us to host and co-host the meeting with Dr. Ratapon. So colleagues, we are going to start the meeting and welcome everybody, and thanks for making time to join our platform, sharing experiences and information from all over the world. We've got two speakers today, Dr. Muir-Green from Jamaica and Dr. Hind Behimba. I will share the first part of the evening talks and introduce Dr. Muir-Green, who is from Jamaica. Dr. Muir-Green has a double major in chemistry as well as biochemistry, and she studied at the University of West Indies. She then went on to do MBBS at University of West Indies, graduating in 2007. She did a MSc in clinical dermatology at the Cardiff University and went on to do a fellowship in hair loss under Jerry Shapiro at the University of British Columbia. She mainly does medical dermatology and works in the government sector as well as privately. She conducts hair loss clinics in both Kingston and Montego Bay in Jamaica, and she's an associate lecturer in dermatology at the University of West Indies. She has a strong interest in rheumatology, dermatology, endocrine derm, as well as cosmetic chemistry, in addition to hair loss. So she's supposed to be covering inflammatory hair disorders. And as we all know, this is a very broad topic. So she's splitting her talk into two, and she'll be covering part one today. So she'll be talking about alopecia areata, central centrifugal cicatricial alopecia, as well as traction alopecia. And I think her next talk will be on lichen planopilaris and all its associated variants. And that will be the next time. So thank you so much, Dr. Llorenia Muir, for making time to share your experiences with us, as well as management of these very important inflammatory conditions. Colleagues, we will take questions after the two talks, but please feel free to send your comments on the chats, and Dr. Ratapon and myself will take note of those and raise the questions later on. Over to you, Dr. Llorenia.
Hi, everybody. I hope you can see me. I'll turn off because my lighting is not the best where I am right now. I would like to thank Dr. Umar for starting this wonderful group and inviting me to talk about on inflammatory alopecia. And today, as I said before, we're going to be I actually had to split my talk because it became quite a Herculean task preparing this. And when I got to about 160 slides, I said, there's no way I can cover this in 20 minutes. So we're definitely going to be splitting it. And I'll start with part one today. So I will find here we go. Let me start sharing. I need to be allowed to share, please.
Dr. Nkosa, could you please let Dr. Green to be a co-host for you to share the screen. Dr. Nkosa, could you please let Dr. Green to share the screen?
Yes, I'm trying to do that, Dr. Ratapon. I'm working on it.
Okay, okay.
Yes, yeah, I got you.
Thank you, thank you.
Thanks. Screen. Are you able to share your screen?
It's still saying disabled.
Oh, okay. Let me get the my assistant to assist.
Hi, Prof.
Yes, please allow Hema.
I'm just trying to check here because I think Dr. Omar didn't allow the participants to share the screen. I'm just checking quickly. Or else they can send the documents to my email address. I'm not sure what we can do because...
I think you can click on participant and click and assign the other to be co-host.
Okay, let me just check. Who wants to share screen now?
Dr. Muir-Green.
It doesn't allow me. It doesn't give me that. Let me just check.
I think Dr. Nkosa should be the host now, and could you please?
Oh yes, Prof. You can click on Dr. Muir-Green under participants, and then go to more, and then maybe make them host.
Okay. Okay, I've done that.
Have you made?
Yes, I have. Dr. Moore, are you able to share your screen?
Yeah, they can share now.
Okay.
I think for everyone, Prof, you have to do that. If somebody has to share, you have to cancel the other host and then the other one can share until you finish your meeting.
Sure.
Yes.
Thank you. Thanks, Sebatu.
Okay.
You can all see my slide now?
Yes.
Yes, we can see your slides.
I see your slide already.
So as again, I said, I had to divide the talk into 2 to 3 parts. And I'm going to be talking about part 1 today. I'm going to be speaking on what is alopecia, and I'm going to speak on alopecia areata, central centrifugal cicatricial alopecia, and traction alopecia. So what is alopecia? As we all know, this is the partial or complete absence of hair from any part of the body. And there are 3 main ways to lose hair: either disease affecting the hair follicle, which is primary alopecia, disease affecting the skin, which is secondary alopecia, or hair shaft abnormalities, whether inherent, which is some inherent hair shaft abnormality, or induced by hairstyle processes that we do to our hair. Alopecia can also be of 2 main types: inflammatory and non-inflammatory. So let's go into a quick history of what we need to ask the patients. You ask them who noticed it first. Sometimes it's actually the hairdresser or a partner who actually saw the hair loss first. What are the first signs and symptoms? Where did it start? Where did it spread to? Is there any signs of inflammation, such as itching, redness, crusting, flaking, whether they have water or vesicles or pustules? If they have any tenderness, sometimes they will describe burning sensation as well as crawling sensation in the scalp. ask if it is improving or worsening with any of the home remedies that they're taking or any other medication that the doctors have started them on, and ask them what they think possibly triggered the hair loss, and had this before. Importantly, you should ask in their past medical history if they have anything like any autoimmune disease, if they have diabetes, hypertension, because sometimes they could be suffering some telogen effluvium or some other entity that could be secondary to the medication that they're taking, like, methotrexate, causing hair loss. Ask if there's a family history of hair loss, and if any traumatic events, traumatic, stressful events such as death, divorce, or bankruptcy occurring before the hair loss started, and any recent surgeries. So after we do the full extensive history, we want to go and examine the patient, and we will look at their scalp, doing a global assessment of the hair loss, look at the distribution, know the texture of the scalp, and as before in the history, you want to look for signs of inflammation, whether it's perifollicular scaling, pustules, papules, erythema, scarring, hyperpigmentation. And you can use your dermoscope at this point. You also want to look at the hair itself for those who have, in certain populations where the actual hair care practices actually affect the hair, you'd actually want to look at this. And you're going to do a pull test and a tug test, and I'll show you pictures of that. So these pictures are courtesy of Dr. Jerry Shapiro. As again, you look at the distribution on the left, and this is somebody on the left with just regular female pattern hair loss. On the right, you will see pictures of the person performing the pull test, where you grab up to 60 to 100 hairs, and you pull from proximal to distal and see how many hairs come out when you pull. And about 10% should indicate some of hairs coming out should indicate that they have some sort of inflammatory process, or they may be having telogen effluvium. The tug test, you should actually grab two ends at the, you actually hold the ends. You could shoot, well, this is not actually showing a tug test, but you would have one hand here and the other one there, and you pull at the ends to see if the hair actually breaks. So distribution, non-scarring, this is a patient on the left with alopecia areata. And this person here on the right actually has female pattern hair loss with some amount of traction alopecia. And of note, you should note, in persons of African descent, we tend to have a tendency to have thinning at the temples in female pattern hair loss. Scarring alopecia, as you can see, the occult CCCA on the left, where you have shortened hairs in the center of the scalp. She has a lot of gray hairs here, and it's not very obvious that they're actually shortened hairs in the central scalp. And then in this middle picture here, you will see that the scalp is actually quite shiny in CCCA versus discoid lupus, where you can see the different, you see the post-inflammatory depigmentation along with the peripheral hyperpigmentation. And I think she has actually hair dye on here, but you can have the follicular plugging or other signs of discoid lupus. So with our patients, you want to do several investigations. You can do your blood count, complete blood count, and thyroid function. I usually tend to do thyroid function tests, ferritin levels, vitamin D, and zinc. I never used to do it I only used to do those mainly for my non-scarring alopecia patients. But what I found is that a lot of my scarring alopecia patients were also having issues with vitamin D deficiency, and a few came back zinc deficient. So I just started doing it in everybody. In certain populations, you may have to consider doing the autoimmune screen, especially in my parts of the world where autoimmunity is very high. You can check androgen levels, especially if the person is postmenopausal. And B12 and folic acid is mainly useful for persons who are vegetarians or persons who have some sort of liver disease in their history or are alcoholics. And scalp biopsy is also warranted, especially in scarring alopecia. You want to see how extensive is the inflammatory infiltrate, the type of infiltrate that is there, and that can also direct the course of what type of medication you'll start the patient on. So we'll start with alopecia areata. As you know, this is an autoimmune condition which is characterized by round, non-scarring patches of alopecia. Everyone has a roughly 2% chance of 1.7 to 2% chance of developing this at any point in their lives. Though it is not definitively proven to be caused by stress, it has been associated to occur after stressful events. And it is typically a self-limiting condition. So what happens in alopecia areata is that inflammatory T cells swarm the hair follicles, and these CD8 positive cells release pro-inflammatory cytokines and chemokines that reject the hair. The exact mechanism is not yet understood, and there is rapid conversion of hairs from anagen to telogen, causing hairs to drop out overnight, and it preferentially attacks pigmented hairs, some reporting going gray overnight. As you know, there are several types. There's alopecia areata, where you have round patches, alopecia totalis, where it involves the entire scalp. This can occur in 5% of cases. Alopecia universalis, which can involve the entire body, usually occurs in less than 1% of cases and is more likely and more difficult to treat. You can have alopecia areata of the nails, where you have you mostly have rough pitting, or you can have longitudinal or horizontal ridges. There's also the ophiasis pattern with a snake-like band-like alopecia at the nape of the neck, and the inverse version, which is at the front of scalp, also called sisyphus. I don't think I spelled it correctly, but the inverse ophiasis. Patches are smooth, non-tender, non-pruritic, and non-scaly, and yellow dots can be seen on dermoscopy. Of course, most people remember about the exclamation hairs, which are defined by a wider proximal end, distal end, and a narrow proximal end closer to the root. Alopecia areata can be associated with other autoimmune conditions such as vitiligo, lupus, Graves' disease, autoimmune hepatitis. Typically can occur at any age group, but tends to be seen more in children and adults. And there's a strong correlation with hypercholesterolemia even in children. So this is one of my patients. This person already had started growing back his hair, and you can see that it's not the best picture, but it's he started growing back golden hairs. Sorry. Right, and these are from the internet, some pictures from the internet. Ayanna Presley, who is somebody in the Senate, I believe in the States, just announced that she has alopecia totalis. And this is a famous basketball player who has alopecia universalis. And this is an example of a person with the alopecia areata of the nails. This is one of my patients who came recently, one of my kids with alopecia areata. So treatment includes topical corticosteroids, mainly your mid to high potency steroids such as your betamethasone, as your clobetasol, and intralesional corticosteroids such as your triamcinolone, given at monthly intervals, are quite useful. And when I was working at, and even out here in Kingston, in Jamaica, when I was working in Canada, we were doing high volume, low concentration injections for our patients. And that seemed to work quite well. Topical minoxidil is used off-label to keep the hairs in the anagen phase longer. Topical immunotherapy, quite well known with disphencyprone and squaric acid dibutyl ester. Problem, and it usually starts off half head for the every week, and you gradually increase you sensitize them first, and then you gradually increase them each week to the strongest concentration that grows their hair, and it should continue on one half of the head until it regrows, and then when they start to regrow, you do it for the entire head. Antholin is also useful. We used to compound with salicylic acid and antholin, and for our patients, and used to for short contact therapy. Oral therapy for the useful for persons who want to do an event, because as we all know, this is one of those, especially persons with alopecia totalis or universalis, it's more difficult to treat, and once they grow back the hair and then they come off the medication, they're likely to have the hair falling out again. So you can start off with prednisone. I usually do weekend treatments, so 10 milligrams or 5 milligrams on a weekend. Cyclosporin grows the hair quite well. However, you have to look out for renal toxicity. Methotrexate, quite useful, but mainly for body hair. And of course, you know, the jaddoskinase inhibitors, which work spectacularly, but they lose the hair once once they come off of the medication. So now I'm going to start off with the scarring alopecia. This involves the destruction of hair follicles, and it usually is a chronic course, and it can result in permanent hair loss if not dealt with from early. So I usually tell people it's like fire on the head, and we need to out the fire as quickly as possible. It causes a lot of emotional distress and reduced quality of life. And patients with scarring alopecia have a greater impairment in quality of life compared to those with non-scarring alopecia. And they complain a lot of psychiatric illnesses, low self-esteem, poor quality of life, and poor body image. There are two main categories of primary types, where the inflammatory cells target the hair follicle directly, or the secondary, where the inflammatory cells target the skin, resulting in secondary alopecia. And it can be defined by the type of inflammatory cells involved, namely lymphocytic, neutrophilic, and mixed. In primary, these are some of the conditions that are noted, like essential CCCA, lichen planopilaris, frontal fibrosis, and alopecia. In secondary, there's discoid lupus, scleroderma, morphea, alopecia, yes, burns, and others, sorry. So for lymphocytic, these are the main categories. And if you want to put in neutrophilic, these are the categories. I mean, these are the ones under neutrophilic and under mixed. And so we'll start off with CCCA, which was defined as a conglomerate of similar presenting diseases in 2002 at the previously known North American Hair Research Society. And it combined follicular degeneration syndrome, pseudopelade in African Americans, central elliptical pseudopelade in Caucasians, previously called Hawk-Comb alopecia, because when it was discovered, it was Black women were doing mainly press on curls, but now we've gone through a whole gamut of hairstyling over the years, and we're still having the same problem. It is considered primary cicatricial alopecia, initially thought with relaxer damage, but as we know, due to Nauza and her wonderful work, we now know that it is familial in inheritance, and there's at least one person in every generation. And it presents with hair loss at the vertex, which spreads centrifugally. It looks like androgenetic alopecia to a lot of persons, and but the scalp is quite shiny. And a lot of, when the patients come in, they will describe tenderness, itching that is out of proportion of with regular seborrheic dermatitis. They can describe the crawling sensation, pins and needle sensation, and burning. And you can have what we call the hair breakage to the vertex, which Dr. Calendar had written about, or called CCCA. And it is magnified by all of the things that we do to our hair, including abuse of relaxers and use of traction hairstyles. So these are some of the differential lists. And this is one of my patients on the left. So you would look at this woman and you just think this person has a male pattern type of androgenetic alopecia. And then this is the person, another person on the right, with she had shortened hairs in the center, which is more in keeping with occult CCCA. So traction alopecia now. This is due to intricate hairstyles worn by Black women worldwide. And well, the most common people who you will see this in is in Black women worldwide. And this is from the hair care practices such as cornrows, braids, twists, dreadlocks, and weaves. Extensions and weaves create even more force due to the weight of the extra exogenous hair, and it's considered a biphasic primary cicatricial alopecia. So therefore, in the early phase, it is reversible. Once it's beyond 5 years and longer, you're less likely to be able to grow back the hair. As you know, it's not limited to Black women. Their Sikhs can experience it. Persons of other races, ballerinas are well known because of how tightly they do their buns, as well as I've had restaurant workers come in with hair loss by the cap that they wear. Pathophysiology, persistent pulling of the hair near to the scalp. Traction attracts inflammatory cells which act on the hair follicle, and this is primarily lymphocytic. And the persistent traction results in protracted action on the follicle, leading to permanent destruction of same. There's marked reduction in terminal hairs, and the terminal hairs are replaced by connective tissue. And however, of note, there is preservation of vellus hairs and sebaceous glands. Typically, the first thing that persons will describe is that they can have a headache after the hairstyling, or they can have soreness of the scalp. And that's the very first sign of traction alopecia, actually, not the actual hair loss itself. There is erythema, follicular pustules, very common in our children. And you can have short broken hairs in the anterior and posterior margins. And there's also a generalized type with widening of partings if the person typically wears the hair a lot in cornrows. The problem is magnified to weak anchoring of hair in skin, especially in Black people, because we have fewer elastin fibers, and there is a greater percentage of hairs in telogen in Black people than other races, which is very interesting. I should say that with the traction alopecia, there is a likelihood of, you should not forget about frontal fibrosing alopecia, because I've had about 2 or 3 patients that were sent to me by doctors thinking they were traction alopecia when they were actually frontal fibrosing alopecia. And you also must think about alopecia areata and trichotillomania. So this is one of my patients with traction alopecia. As you can see, there is greater loss behind the anterior margin, and this is what we call the fringe sign here. Along, you can see my arrow. This is the fringe line. This is the preservation of the most anterior hairs at the hairline, and it is usually indicative of traction alopecia. So with respect to management of scarring alopecia, remember, we don't have a lot of studies, unfortunately, in terms of the management of scarring alopecia out there. And we have to, of course, manage the expectations from the patient and discuss in detail the likelihood of treatment actually helping the hair to grow back. So prior to this, we were having issues with hair growing back, especially with CCCA. But now we have a greater armamentarium of products available. We're now using the off-label minoxidil. We use a topical potent steroids, clobetasol or betamethasone. Tacrolimus, the 3% is better than the regular one that it's not, I don't think it's 0.3, it's 0.3%, sorry. And then the topical metformin, which is, I think, is a superstar. This was actually reported on by Dr. I think it's Agu in a few months ago, and she was looking at 2 cases of patients that were recalcitrant with the normal therapy, and she's used the metformin with the belief that it's useful for, it has been shown to be useful for scars in mice, and the persons actually started to grow back their hair. I've actually started using it, so I'm actually collecting my pictures to probably show people in the future about the before and after of persons using this. Because remember, I work in the government system mostly, and so I can only use what is available to the through the government. Orally, we use antibiotics such as the anti-inflammatory antibiotics such as doxycycline 100 milligrams BID, anti-malarial such as the hydroxychloroquine 200 milligrams BID. We can also use off-label the finasteride 2.5 or preferably 5 milligram or dutasteride 0.5 milligrams daily. And consider oral minoxidil or spironolactone for underlying female pattern hair loss. So a lot of times we just focus on the scarring alopecia, but we forget that these people are people, and therefore as we age, almost everybody has some amount of female and male pattern hair loss. So they probably have 2 or even 3 competing types of alopecia occurring on one head. Intranasally, we can use the triamcinolone alone for a max of 20 milligrams monthly, and giving them break or holidays every 3 or 4 months. And we can also offer procedural things. I'll be soon finished, such as our platelet-rich plasma. Dr. Ose Tutu gave a brilliant workshop for the recently held Caribbean Dermatology Association meeting, discussing all of her experience in hair transplantation, along with platelet-rich plasma and the use of stem cells, exosomes, etc., for the growth of her patients with CCCA and traction alopecia. And thank you.
Oh, thank you so much, Dr. Green.
Yes, thanks, Dr. Green. Yeah, you may take over, Dr. Ratapun. Thank you.
Yeah. Wonderful lecture. And anybody have any question? Dr. Green.
Hi, this is Dr. Ose Tutu. How are you?
Yes, please, Dr.
I had
Tutu.
a question for Dr. Green. Who is doing transplants in Jamaica? Because I do have requests for people, in Jamaica and the Caribbean, and I'm very much interested in continuity of care. So, if there's somebody in that area, that would be great. And are you able to do PRP in the government hospitals that you work in?
Okay, thanks for that, Dr. Osetutu. So for currently, I think we have about 2 persons doing hair transplantation, Dr. Mambe Alexander, who, and I think a plastic surgeon. Those are the only 2 persons that I'm aware of at the moment. In terms of, but Dr. Mambe Alexander is mainly strip harvesting, so that may limit the persons who want to go because they may not want the scar. With respect to the platelet-rich plasma, people offer it privately. Several dermatologists are offering that, and in the public sector, I'm trying to get that implemented. I actually had sent for procurement of some centrifuges, but because of COVID and all the drama surrounding COVID, everything has been shunted towards, COVID. And so I'm not quite sure how soon we'll be able to implement this.
Thank you.
Thank you. Okay, let's move to the second speaker. I would like to introduce Dr. Hind Behimba. She's a dermatologist from Rabat, Morocco, and working in private clinic. And she also an EADV member and laureate for Sorbonne University Diploma in Hair Disease. She interested in hair disorder and hair restoration. Welcome, Dr. Hind. could you please open your microphone, Dr. Hind?
It's done.
Thank
Are
you.
you hearing me?
Yes, right.
Yeah.
Good.
Okay. Thank you, Dr. Ratapon, for this kind introduction. So I'm so glad to be with you during this monthly session. I want to thank Dr. Sanusi for joining me to this group, and by the way, I'm grateful to Dr. Bisanka for his permanent support. I will share my presentation, so if possible to allow me to share it.
Or Dr. Ratapon, can you just guide Dr. Muir how to make myself co-host or the speaker co-host so she can share?
Yes,
Okay.
I just did it.
Okay, good.
Okay,
Good.
thank you. So it's my pleasure to share with you some knowledge about trichoscopy of hair disorders. Widely used in dermatology, trichoscopy is the dermoscopic examination of hair and scalp. It may be used to examine scalp hair, eyebrows, eyelashes, beard hair, and in some cases, body hair also. The word trichoscopy was used in the first time 14 years ago, since 2006, and it means that many publications and many work has been made until now with studies done in both African, Caucasian, and Asian population. So why using trichoscopy? The answer is because it has many advantages. It's fast, quick, non-invasive, generally well accepted by all patients. It will reduce the need for scalp biopsy and also guide the biopsy sites in scarring alopecia. And it's useful not only for the diagnosis of hair disorders, but also for therapeutic monitoring and follow-up of our patients. The second question we could ask ourselves is, which dermoscope should I use? Well, all trichoscopes or dermoscopes may be used to perform trichoscopy. The manual ones, the more expensive ones using video dermoscopy, and also dermoscopes with UV enhanced light, which are used to help diagnosis of some hair disorders that we will see later. But the most important thing we should keep in mind is that no one of these dermoscopes will give us the diagnosis. Maybe there are some applications that may count the number of hair or measure the thickness of hair, but none of these devices will give us the diagnosis. It's our interpretation and it's our knowledge in trichoscopy who will allow us to do that. So that's why we need to learn about trichoscopy from experts and attend meetings and now webinars and web learnings. When to use or not immersion fluid? As a general rule, we start the examination with dry dermoscopes, and then we may use an immersion fluid if necessary. The choice of these immersion fluids may be done by using water, echographic gel, alcohol, and according to Antonella Tosti, there are some few simple points that should be taken into consideration. Contact dermoscopy is always necessary if an immersion fluid is being used. Besides, and in devices with non-polarized light, it's required to use an immersion fluid to cancel out reflections from the stratum corneum. Also, immersion fluids may hamper evaluation of scaling conditions and visualization of vellus and white hairs. And as excessive scaling may interfere with visualization of underlying trichoscopic features, elimination of scaling with immersion fluid is sometimes desirable. What about using trichoscopy during this coronavirus pandemic? Well, some authors say that we must nowadays perform trichoscopy only in selected cases in which we see that trichoscopy will change our treatment decision. But in my opinion, we must use trichoscopy for all our patients, but to keep in mind to use adequate personal protective equipment. So please don't forget to wear glasses, to wear gloves, and to disinfect your trichoscopes just to be in the safe side. So we are in dermatology, and if we want to learn about trichoscopy, because we must start by basics, we have to know and to identify some basic structures while using our trichoscopes. It would be by examining the hair shafts, the follicular openings, the skin surface, and the blood vessels. Let's start with the hair shafts. Normal scalp contains normally and is characterized by follicular openings containing 2 to 3 terminal hairs of uniform thickness and color. And in normal dark skin scalp, we always see a perifollicular pigmented network, which is formed by pigmented line corresponding to wheat-rich melanocytes that surrounds hypochromic area, which are fewer melanocytes residing in the suprapapillar epidermis. In abnormal situation, trichoscopy will show us some pathologic features, and the most famous ones are exclamation mark hairs, comma hairs, coiled hairs, flame hairs, vellus hairs, and we will see in detail all these abnormal hair shafts during this presentation. Besides, trichoscopy will give us information about follicular opening, called also dots. It will show us yellow dots, which are follicles plagued with sometimes keratin or sebum. Also, we may see black dots called also cadaverized hair, which are follicles containing broken hairs remnants. And in some cases, we may see white or white pinpoint dots, which are corresponding to fibrosis, but also present in normal dark scalp with a regular distribution between the follicular units and which correspond to follicular and sweat gland openings. Moreover, using trichoscopy will give us information about skin surface, especially in some scaling condition, with giving us information about the form and the presentation of this scaling. Are we facing a perifollicular or tubular scaling when we see that, especially in lichen planopilaris, or are we facing diffuse scaling, and it's the case in psoriasis or in seborrheic dermatitis. Last but not least, trichoscopy will give us information about blood vessels, and in both Caucasian and normal dark scalp, it's presented such as thin arborizing vessels, little bit more visible in white-skinned scalps. In other abnormal situations, these vessels are becoming thicker especially in connective disease tissue, but also in as a side effect of steroid-induced atrophy. Well, once we had make the basics and identified the main basic features of trichoscopy, the next step is to evaluate our patient's hair loss while using our trichoscopes. Many situations are possible. Are we facing a diffuse hair loss, such the case in androgenic alopecia, alopecia areata, or also telogen effluvium? Is it a focal or patchy hair loss? And it's seen in traction alopecia, but also in lichen planopilaris. Is it a marginal hair loss? And the main common cause is frontal fibrosing alopecia. And or are we in a hair loss condition with inflammatory scalp disorder, which are leading to a scarring condition that we could see also in advanced stages of non-scarring alopecia. Let's start with androgenic alopecia. And in this case, the clinical diagnosis of early forms of male and female androgenic alopecia is sometimes troublesome. And in this case, trichoscopy may especially be very helpful. The scalp examination while using our trichoscopes should be done in the frontoparietal area, approximately at the cross between the nose line and the ear implantation, and we should not forget the vertex area in male. Hair diameter variability reflects hair miniaturization, which is pathognomonic and specific to androgenic alopecia. So, in trichoscopy of androgenic alopecia, we have some specific and sensible criteria or signs. Trichoscopy will reveal single hair in follicular ostium, as we see in the dermoscopic feature. The hair shaft variability involves more than 20% of all the hair. We see also vellus hairs which are short, thin, and growing hairs. And recently, some authors have reported the presence of a particular sign, which is perifollicular hyperpigmentation, seen in early stage of androgenic alopecia, and it may be a poor prognosis sign which may indicate the use of short period of steroids in those stages. In advanced stages of androgenic alopecia, we may see yellow dots, as we can see in this picture, but also empty follicular ostium, and the pigmented network is conserved in both bald, dark-skinned, or sun-exposed area. What about alopecia areata? Trichoscopy is useful not only for the diagnosis of alopecia areata, but also for the therapeutic monitoring and the follow-up of our patients. In this case, the most famous sign of alopecia areata is the famous exclamation mark hairs, which are hairs of at least 1 to 2 millimeter long fractured hair. We may also see black dots, or the called cadaverized hair, which are follicles containing broken hairs remnants. As in alopecia areata, the conflicts and the inflammation is especially deep around the papillar bulb. We may also see in trichoscopy the presence of yellow dots which are follicles plugged with keratin and also sebum. Other hair shaft abnormalities may be seen, such as flame hair and also coiled hair. In dark-skinned scalp, we have the preservation of the honeycomb-like pigmented network. We may see numerous white dots. Exclamation marks are also seen in this type of scalp. We may see also broken hair and black dots. There is a specific predictive score of alopecia areata that is useful to use for judging and for the therapeutic monitoring of our patients. It may be useful to know if the treatment was efficient or not. A particular form of alopecia areata that we should know also in trichoscopic features is alopecia areata incognita, called also by some authors simply diffuse alopecia areata. In this case, trichoscopy will show us diffuse shedding of telogen hair, yellow dots, hypopigmented vellus hair can also be seen, exclamation mark also, and black dots. What about the use of trichoscopy in telogen effluvium? Well, there is no specific trichoscopic sign about this entity, but it may be suspected when we have empty hair follicles, yellow dots, short and dark regrowing hairs with normal thickness. In trichotillomania, which is seen often in children, but also in stressful patients, we may see coiled hair, which are broken hair that curl back in their end. We may see also flame hair, and also we can see, we don't have it here, but we can see a perifollicular erythema, which is a sign of the bleeding caused by the traumatism of trichotillomania. In tinea capitis, fungal hair parasitization results in bending and cracking of the hair shafts at different lengths. UV enhanced trichoscopy may help us to do the diagnosis, but if we don't have it, it's not a problem. We may see the famous sign of comma hair, which is short, C-sharped hairs. We may also see zigzag hairs, eye hairs, and Morse code hairs. In traction alopecia, which is common in African descent patients, but also in all patients from the worldwide globe, due to the new hairstyle forms, trichoscopy reveals in early stage the preservation of the honeycomb pattern normal dark scalp, early distribute pinpoint white dots, and the reduced hair density with numerous vellus and miniaturized hair. In advanced stage of the disease, we have pinpoint white dots, but in irregular distribution, and the presence of irregular white patch. All is telling the flow up and the evolution on scarring alopecia. That's why we should make the diagnosis in early stage of this traction alopecia. Okay, no. So we arrived to the unfortunate and scarring condition that we don't want all patients to have, but we should diagnostic it first. And in trichoscopy, the scarring alopecia are Alopecias are characterized by decreased hair density, whitish area, and variable degrees of absence of follicular opening. And trichoscopy will be a useful tool not only to distinguish this scarring alopecia from a non-scarring one, but also in some cases to select the optimal biopsy site. Let's start with the most famous and the most common cause of scarring alopecia, which is lichen planopilaris. Clinically, we have irregular patches of hair loss, and trichoscopy reveals the absence of follicular openings, whitish perifollicular scales surrounding the hair shafts at their emergence with this characterized tubular scaling. White dots are also seen, which correspond to fibrosis. Blue-gray dots may be also seen, and in dark-skinned scalp, we have the persistence of a normal pigmented network inside the plaque of hair loss. For frontal fibrosing alopecia, which is generally considered a clinical variant of lichen planopilaris, we have in trichoscopy a perifollicular scaling with the absence of follicular opening, and the specific signs is the abrupt interruption of the hairline with absence of the vellus hair. We should, of course, well examine our patient clinically. And for example, in this one of my patients, we have also the ascent of the eyebrows, and we may guess here the lichen pigmentosus and some also follicular papules. Let's move to the central centrifugal cicatricial alopecia, which is common to African women. And in this case, trichoscopy will reveal the preservation of the honey pigmented network, which is proper to dark skinned scalp. But also it will show us pinpoint white dots, but in a regular distribution, peripolar gray, white halo, shaft variability, and perifollicular erythema. There are also other inflammatory scalp disorders that can be seen in scarring alopecia, such as discoid lupus erythematosus, and in this case, the most pathognomonic sign is the thick arborizing vessels, but also the presence of red dots around follicular opening. In folliculitis decalvans, the most important sign is clinically and also while using dermoscope is the tufted folliculates. And in dissecting cellulites, we have yellow dots in 3D presentation. We may have red dots and also some black dots which correspond to the follicles containing broken hair remnants. Trichoscopy may also be useful in the diagnosis of hair shaft disorders, especially while seeing elliptical nodes in monolatrix abnormalities, but also in pili-torti abnormalities, which we see flattened hair shafts with regular twists at irregular intervals along the long axis. Okay, we should be aware of some pitfalls when using trichoscopy. The most important one are scalp deposits, which may be due to environmental particle but also the use of some powder and hair fibers. The second pitfall is scalp staining that may be due to topical medication, especially Ontralin in the treatment of alopecia areata, but also in the case of scalp tattoos. And we have also the last one is the hair shaft deposits, which can be caused by dry shampoo, hairspray, or other hair styling products. But in this case, we should just wash the hair with shampoo. Okay, to sum up and to crown the whole, I gave some 5 take-home message just to memorize the efficiency and the importance of trichoscopy in our practical daily dermoscopic use. Trichoscopy is useful to diagnose early scar in alopecias and to select the optimal biopsy sites in these patients. Trichoscopy can easily distinguish hair loss from hair breakage and provide good information on hair shaft damage. The pigmented scalp is rich of information, and as we are African and we may have African patients, so please pay attention to the particularities of dark-skinned scalp and be aware of possible pitfalls, including scalp staining and hair shaft deposits. And also be aware of the fact that many disorder features in trichoscopy can be present in the same scalp. One patient or the same patient may have both traction alopecia, but also centrifuge alopecia or lichen planopilaris. Thank you for your attention and welcome one day in my city. Thank you.
Thank you so much, Dr. Hind. Thank you for your informative lecture. Very good.
Thank you.
Any question from the audience?
Yeah, it's Dr. Tutu again. I just had a question about the dermoscopic. I have, a dermatoscope that I use all the time, and I'm looking for another one for just sort of patient presentation. I was wondering if Dr. Hind had a suggestion or anybody had a suggestion that they like that works really well, and that, you get good views when you project it onto screens.
I would like to share my experience. At first, I used to use dermoscopy and share the picture to the screen because of the patient can see the abnormality, so you feel comfort to talk with you and see the progression. But the drawback is you must take more time for each patient. If you have many patients, you must manage the time. Thank you.
Dr. Setutu, I think the easy way, you have the Firefly. I think you can Google it on Amazon, and it's a wireless device that can be hooked up to either a monitor or to your laptop. I think it's an easy and simple way of doing trichoscopy without really wasting too much time in a consultation. By the way, Hind, very good presentation.
Yes, thank you.
Yeah.
I have a question for Dr. Hind and for Dr. Green, if she's still there. Great presentation, by the way, Dr. Hind. I have a question about the CCCA. between like an active CCCA or when it's quiescent, do you have some sign that could change on the trichoscopy or no?
Yes. For activity, are you hearing me?
Yes.
Yes.
Yes. I think for the activity of CCCA, you will, as mentioned, you will see the preservation of the pigmented network, but you won't see the white pinpoint fibrotic dots. And besides, in the marginal area, you will see some perifollicular erythema. This thing will not be seen in CCC with the advanced stage.
And for Dr. Green, if she's there, I would like if you can a little bit explain a little bit about the topical metformin or whatever, whoever has an experience with that, because it has been described a little bit now for treating. I saw, if I understand, treating traction alopecia with that. So is anybody can explain a little bit the physiopathology and what is the experience? Do you use it as a sole treatment or do you combine it with the classic topical corticoid or whatever?
From this report that I saw with Dr. Agu, she had used, they have their formulation written in the report and they put the metformin in the lipophilic base. It's called lipobase. So I don't have that in where, so what I did was to actually compound it into glycerin in aqueous cream, which was quite useful because a lot of the patients said it's actually nice and soothing to the scalp. And the patients, when they started using it, said that the scalp actually felt better. I've been using it in combination with they use it once a day. Some patients were using it twice a day by accident, and they didn't have any further issues with it because you know that the topical metformin is used as for diabetics as well. So, you know, the concern was whether or not they would have some issues with using the topical metformin and affecting their sugar, but they had no issues using it twice a day. So I would use it once in the morning, and I use the Dermavates or the Clobetas or whatever in the evenings. And they seem to do quite well with it so far. I literally only started using it within the last 3 to 4 months, and I usually see patients every 4 months. So I'm now seeing them come back. So I'm not now able to, you know, look back and see how they're doing with it. I think her reasoning, as I said before, for implementing it was because of the scar formation, the collagen deposition, and metformin seems to reduce that or reverse it in mice or something like that. So they decided to try it in, and that is the reason why she started using it. And in the patients that she's used it, who were, you know, they had already gone through their triamcinolone injections, already gone through, you know, the typical doxycycline, everything, and they had failed everything. And she added that. I think some persons got it as monotherapy and others got it in combination with topical corticosteroids, and they eventually improved. I hope that's helpful.
Okay, thank you.
Thank you. Okay, any more questions?
I shared the link to the article on metformin on a chat. So just for those who want to read that.
Yes, you did. Yes, you did.
Thanks, Dr. Bisanga. Dr. Hindi, thanks to both of you for really lovely and very informative presentations. Would you be so kind and make Dr. Uma the host so that we can complete recording of the talks so we can share with everyone later on?
Thank you.
Yeah. I think we've come to the end of our today's talk, and thanks to everyone for attending, and thanks for the questions and for the amazing talks. You know, I know it takes time to present and prepare all the presentations. We really appreciate your sharing your experiences with us and making time also to attend. Dr. Ratwindi, would you like to say anything?
Oh yeah, I also thank you everybody and hope everybody safe from COVID-19 and see you very soon.
Bye.
Bye.
Thanks again.
Goodbye. Goodbye, everybody.
Thank you.
Have a
Bye
lovely
bye.
evening.
Thank you.
Thanks.
Bye,
Bye-bye.
everybody. Bye, everyone.
Bye.
Happy New Year to
Bye.
everyone.
Prof,
Yes.
Dr. Hindi has not made me host. Before she leaves, please.
Oh, Dr. Hindi,
Yeah, I'm here.
Can you
please
make me
make
host? Can you make Dr. Uma host, please, before the meeting
Dr.
ends?
Uma host. Yeah, so he can complete. That's my PA trying to assist, please.
Okay.
You can just click
So she
on
can.
his name and then go to more and make host
Okay.
under participants.
Je fais un petit route. Je sais pas. On va mettre l'enregistrement. Is it okay?
Yes, it's let me see. No, it's not okay yet.
Non, mais animateur, oui. I think it's okay now.
Yes, it's fine. Thank you.
Okay,
Thank you.
thanks. Thanks, Dr. Hind, and thanks, Bato, for assisting. Good night to everybody.
Okay, bye.
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 Bye.